Coming up next on Uncommon Sense, join me as I interview Dr. James Breen, a physician who's been practicing for over 20 years and is now starting to think about a distributist way to do medicine. Welcome to Uncommon Sense, the official podcast of the Society of Gilbert Keith Chesterton. I'm Grettelyn Darkey, your host, and I'm happy to be joined today by James Breen. Hi, doctor. How are you?
Very well, Grettelyn. Thank you so much for having me on the show.
It's great to have you. So first of all, why don't you just give like a brief introduction for our listeners so they can find out who you are?
Sure. So like you said, my name is James Breen. I'm a family physician, about 20 years into practice. I originally hail from Northern Virginia, outside of the Beltway. I'm always clear to point out I'm from outside of the Beltway, but grew up in Northern Virginia in a Catholic household, went to University of Virginia for undergraduate, pursued my medical education at Jefferson Medical College in Philadelphia, and then my internship and residency in family medicine in Rhode Island at Brown. And then entered practice in a community health center setting in the borderlands of southern New Mexico, which was a very intense experience, taught me a lot clinically, and also got my mind thinking a little bit about how we can better care for communities, care for the poor, people who have limited access to care. Then found myself working in a large multi-specialty practice in southeastern Florida with a young family, a newlywed with a young daughter, and felt and experienced the grind of clinical productivity medicine, which really got me thinking much more about what it was that I had embarked on when I decided to become a physician, and much less a family physician in primary care. And I began to do some mental experiments, read about a mental experiment of a physician named Dr. Gordon Moore, who at the time was in Rochester, New York, and had published an article, a thought experiment that he had undertaken, which basically he asked himself, could I take care of my patients adequately and provide them good care for $1 a day, and strip down all of the unnecessary and frivolous things that were contrivances in medicine, and really just simplified everything down and started a movement called the micropractice movement. And so that really got me thinking a lot about how to apply real common sense to medical practice, which is so lacking in many areas of what we do in primary care in particular.
I think it's lacking in a lot of things we do in life.
Yes, absolutely.
No, that's very interesting though, and it kind of just a little side tangent. It reminds me of what we're doing with the Chesterton Schools networks. Where it's that's the whole idea, is you pare it down to what kind of education is really important, and then that's what you have to pay for, right? So that's interesting, and that's really great, because if you think for like 1 minute, in your mind that medicine had to be done before insurance in a way that was affordable. So like it's been done for a long time. So how do we get back to that? Tell us a little bit about your ideas there.
Sure. So I think first, for many of your listeners and viewers who may not be inside the sausage factory of medicine, there is so much that is going on. I think our healthcare system has really turned, and I also hesitate to use the word healthcare system. I think that really, again, sort of commodifies it, but really medicine has become so turned towards utilitarianism that we really lose sight of what actually it means to take care of human beings. I think medical students, certainly pre-medical students in college, and then those who enter medical school, they have that humanitarian streak in them, and that longing to take care of people. We're in the middle right now of I'm a faculty physician in residency training as well, and we're interviewing applicants, and their personal statements really speak to that humanism that they long for. And then I think many times physicians end up in practice and they see the residents ask all the time about coding and billing, how do I properly code this? And you realize how far removed we've come from, like you said, taking care of patients. So I always tell them, what would Sir William Osler do in this case, right? And he would not care if you used the modifier with the thing. But anyway, people don't realize how distorted that has become. My personal feeling is that we need to look at how we can strip that down and create a model that responds to the telos of medicine, which is taking care of people. And there are physicians doing this, and I have done a lot of thinking around this and writing on this topic, and so that's what we're here to talk about.
Yeah, that's beautiful, and it's sort of, I would imagine, countercultural to the big business model that's out there, but it's very needed. I think this big business model can lead to some dangerous things. Euthanasia. Certainly, there's issues with abortion, and but yeah, this is a very countercultural, counter that culture measure, and it's great to see.
So I guess thinking about how to get there, I've thought about this a lot throughout my career. And if I think about it, some of my earliest projections of my future career, I think I was probably an anonymous distributist is the term I would use before I really knew what distributism was. The idea that we could subsidize care for some patients through by taking care of other patients who would be able to provide to subsidize that care. I think divorcing that to a large degree from the current payment model is really important. Now, I'm no economist, but it seems really out of balance when we talk in economic terms. We talk about paying for primary care the same way we talk about paying for care in the trauma ward or the ICU or the operatory with surgery. So it's what I do as a family physician really should be accessible to everyone. Without having to rely on this concept that insurance or government programs are necessary to access basic primary care, and that's the premise of my entire model that we're going to talk about here, and not just to speak of it in economic terms, although I think it's clearly important, but part of what is gained by severing that link with those third parties is the freedom and the independence to be able to practice according to one's conscience. I think conscience rights is another area that is deeply, deeply assaulted these days. Not just in the U.S., of course, it's much worse in many other Western nations, but it's coming soon and coming fast here. And so I think that in order to preserve what remains of that, it's imperative that primary care medicine forge its own path.
Yeah, amen. I mean, there's the, if you're not taking government money, you don't have to technically necessarily bow to the government and everything. So that's great. That's wonderful. Great. So let's talk a little bit more then about not necessarily the economic side of it. So what are you trying to aim to do for people specifically?
Sure. So I've come up with this idea that I'm working to develop, and it's really so like the Gordon Moore experiment I talked about before, it was really kind of a Walden Pond experiment. An individual in the woods with a laptop and no one else taking care of his patients for $1 a day. My idea is that we really need to develop this. As Christians, we're called to community, and really. I think that's what we're called to take care of one another and to collaborate with one another. That's really how we're designed, right? So I've come up with an idea of sort of these 5 pillars that really are reflective of Catholic social teaching, and that I think are what best exemplify this model to kind of give some clarity to it. So I think that truly Catholic healthcare puts human dignity at the center of all that it does. And so kind of to your point, Grettelyn, about euthanasia, abortion, and other utilitarian enterprises or views that unfortunately are largely espoused by many of our mainstream medical societies, for which I am deeply saddened. I think a Catholic healthcare response has to put human dignity at the center. Secondly, it does need to respond to the needs of the poorest of the poor, and it needs to offer its care to everyone. So we're not speaking about a model that only serves adherents to our faith or people who have particular economic means. It needs to be available and accessible to all. Because it is part of a personal vocation, it's also rooted in a local call to service, and that's sort of the call to subsidiarity. So it needs to serve the community where it is. It has locality. It has an actual presence in the community where it is.
Sure.
And then also because of its conviction to the gospel, like we said, I think a truly medical witness needs to remain independent of the influences of those third parties for the reasons that we've already touched upon. And then finally, I'd say that practices that adhere to these Catholic social teaching principles need to be good stewards of resources. That's another area where I think our current healthcare system falls abysmally short, is just being a good steward of resources, both economic resources as well as personal talents, and really utilizing and putting people's talents to use in service of one another.
Beautiful. Yeah. I recently had a baby, and
Congratulations.
thank you.
Yes.
But it was, it's always an experience, and it's a very medical experience. And it was interesting to me, like how many things were offered to me that I, looking up on my own, was like, I don't think I need this or this or this or this or this. And like, it just sort of became clear after a while. I'm like, are they just trying to make money off me? Not trying to say anything about anybody, but yeah, it gets a little fishy after a while, and you're like, could it be a lot cheaper if we just cut all this stuff that didn't need to be there?
Yes.
Yeah.
Opacity is definitely a hallmark of the system we have now. It's very difficult to understand what's being offered and the reason for it, which is all the more reason why I think that trust is the ingredient that is the most important ingredient in medicine. And that's where I think a good primary care physician, a family physician, comes into play, to be able to offer that trusting relationship. I think that unfortunately is, again, it's become commodified, and in many places, whomever the language is important as well. So whomever the provider is who can see you. So provider being that anonymous term, that agnostic term that doesn't specify the credentials or the training or the individual whom you will be in fact cared for today. It's sort of, physicians and patients become interchangeable, and it's really more about what fits our schedule. Sometimes I tell that in sort of jokingly to residents or to patients, like, it's like trying to book a flight to Atlanta. It's like we can route you through St. Louis, or we can route you through Newark, and that's not how medicine should be. Medicine should be about the person whom you trust taking care of you, and then also helping you distill out, like you were saying, what are the things that I really need? What will help me to get better? Yeah.
And what's necessary, and what can be left for emergency situations.
Right.
So let's delve a little bit deeper into the distributist aspect, and I'd like to know, I know Chesterton, so like, how has reading Chesterton and learning Chesterton kind of informed any of the system? Obviously, there's a distributist element, but like, how does that play out for you?
That's a great question. I've been reflecting on that since I knew I'd be coming on the podcast. And I actually am very, I'd say my knowledge of Chesterton has come about slowly over time. And like I said before, if I was an anonymous distributist, as I began to think early in my medical practice, I was also somewhat of an anonymous Chestertonian. And I would, of course, his joyful and very pithy sayings strike listeners and readers very acutely. And so I found him creeping in as I've thought through this process of how to make medicine more distributist. So it's impossible to pin down exactly and to cite line and verse where and how he's influenced me. But I'd certainly say that he's been a large influence. And then culminating in my joining the Chesterton Society this past year, which I was very pleased to do. Not in time to join you all in July for the conference, but I'm hopeful I'll have a chance to join in Philadelphia next year.
Yeah. Come on up to Philadelphia. You've been here before, so
yes, that's right.
trip down memory lane. But yeah, that's and I, as we were saying at the beginning of the podcast, that Chesterton's sort of common sense element is really coming through in a lot of what you're saying. That's great. Yeah. Great. So just tell me some more. Like, what would it look like? Do you have any idea?
So what I am beginning to sort of map out this idea of a distributist model, something that I term it. I term it the Benedict Medicine Consortium. So the idea being that much like Saint Benedict's trip to to Subiaco, to the caves of Subiaco, to form the monastic life, Christians need to really preserve what is essential in our core and inherent beliefs, and also to be able to manifest that to the world, right? So we're not called to just shy away into a cave, but that we're meant to project that out and use that to lighten the world and to be salt of the earth. I think that the important thing, though, is that we also recognize that there are many things with, we can't negotiate necessarily or compromise with the world, but we do need to illuminate the world. And so my idea is to look at primary care medicine as a way of bolstering and supporting thick Christian community. And I think that nowadays there is such distrust. As you alluded to, there are many people who are very distrustful of medicine as a profession and of healthcare and healthcare providers and all the rest of it. I think these recent past few years have really undermined whatever trust was left in many institutions, and medicine is not exempt from that. And so my idea is really to look for a way to draw like-minded primary care physicians into communion, again, across geography, and be able to help one another in developing this notion of the distributist medical practice. That is, that adheres to these principles of human dignity, solidarity, subsidiarity, good stewards of resources, and severs those relationships with third parties that unfortunately do control much of what physicians and practices are able to do or not able to do. I think that's really important to emphasize, that this is it's open to everyone. It's not strictly a Catholic model or even strictly a Christian model, but that does not change the idea that there are two moral agents in every doctor-patient relationship. I think that's another thing that the mainstream secular medical establishment would rather not discuss, which is that as physicians, we are very much told to leave our values at the door. This is really about serving the patient's wants rather than the idea that we as physicians have any wisdom to bring to the discussion. So we've really turned medicine very much into a commodified exercise. So all of that is goes into the practicality of this concept of the Benedict Medicine Consortium. So it's meant to be a community of physicians, but also a community of individuals and families who wish to engage in this type of medical care and find physicians and other healthcare professionals in their local area who are able to do this. Again, this is a very nascent idea. I'm developing it almost as we are speaking now, but I'm so excited to be able to articulate that, because I really believe that it's critical that we do these things and we do them promptly, because I'm afraid that time will also run out and it will become too late in some respects as there becomes more and more encroachment over how we practice.
For sure. And I think a lot of people saw during COVID, not only in the medical profession, but something that we saw was the breakdown of supply chains. And it really hit home for a lot of people that not being local is kind of a big problem. And, if we look at our medical system, it's like one of the least local things about the US. So this is great to see. I'm also seeing some echoes of Chesterton in the sort of like looking to tradition. So have you been able to look at older models of medicine, and has it helped you at all in this concept?
Yeah, so I would say that I drew a lot of my inspiration for this just even studying the history of my own specialty in medicine, family medicine. So a lot of the originators of the specialty of family medicine in the 1960s came out of the old, general practice model, that, what people used to call GPs, and then formalized into a specialty, and in the late 60s, termed family medicine. And particularly these were folks who were really looking to establish that idea of continuity and relationship with patients in their families, in the context of their families and their communities.
Yes.
One physician in particular, Dr. Lynn Carmichael, who actually practiced in Miami and started the family medicine department at University of Miami, was one of the pioneers in this area. And I read an interview with him I think it was probably an interview from the early 90s. And he was asked about his thoughts about the development of the specialty. And he lamented that at this point, and again, in the early 90s, medicine had already begun the trajectory to where we are now, in terms of the commodification of the specialty. And he basically lamented, saying that for him, the best times of his career were when he was in a small independent practice in Coral Gables, Florida, at the very beginning of his career, taking care of individuals. And that's where he really felt the most like a physician. And that essentially his lament was that, the physician has now kind of become a company man, kind of lives and dies with the fortunes of the company. And that's really what we've kind of become. And it was a sad there was a lot of pathos in that interview, but that came through on the page, but it spoke to me in a very, very personal way, because I think that many physicians share that. I think many of them don't quite know what to do with that. And so it kind of just becomes an exercise in, rinse, repeat, and wake up tomorrow and do it again. So, but that's largely influenced how I think about this.
No, that's wonderful. And it's kind of insane that, you can have the same hairdresser for 20 years, but to find like a doctor that you're going to see every single time is kind of difficult. I mean, again, I just had a baby. This is my third. And I went through medical midwives, and it's the same with OBs, I understand. You don't know who you're going to get when it's actually time for the birth. And this was the first time I actually had met the midwife before the birth, which is kind of nuts. So like it's just this idea of like, who thought this was a good idea to, like you said, the patients and the doctors are interchangeable and it kind of doesn't matter who you're seeing. Like, yes, it does. And especially like you said, in this day of when freedom of conscience is on the line, and people aren't respecting really a certain set of morals and ideals, and we know whose those are. And if you want to see a doctor who shares those ideals, it's hard. It's really hard to find that person. Yeah. So.
Yeah, I think that in a lot of ways, just learning about the Chesterton Schools Network, that I think is a perfect analogy for what we're talking about. And I think I've thought for a long time, even before my awareness and study of the Chesterton Schools Network came about, the idea that medicine is following largely in the trajectory of our public education system, which is the idea that once it's sort of decreed to be free, let's say, and I use that in air quotes, of course, because it's not free, and families pay on average, employers pay on average $20,000 to $25,000 for a family of four in premiums for your health insurance. So when you pay that $25 copay to go see your primary care provider, right, which is the language, that's really not the cost of your medical care. But the idea that we've kind of created this dissociation between the value of something and the price of something. And education is very much that way. And so it takes a certain amount of conscientiousness and awareness to say, wait a minute, what are my children being subjected to here? Is this really the broth that I want to raise my family in? And then for those who say no, it's an active action to go ahead and intentionally seek out an alternative. And I think in medicine, it is very much the same way. In medicine, we've sort of demonized that. I won't say we. Medicine in general, society demonizes that by saying that, now suddenly you're against the idea of caring for everyone. My idea is, no, it is not about that. This is not a strictly libertarian idea. This is an idea that we should have options, and those options should be made as accessible and easily available to people as possible for those who wish to engage in this model.
Wonderful. Yeah. And it's, it would be great to see like some simplification too. I know you talked before about billing, coding and all that. And, my husband and I have tried to go through independent physicians, and oh my goodness, like they don't make it hard, but everyone around them does. Like to get your tests and to get it's kind of this big other language.
Yes. So I can get, just to put it in more practical terms, I'm a lot of these ideas are things that are being done in a model called direct primary care, which is sort of, I think of it as an economic chassis, but in and of itself is insufficient to explain fully what it is that I'm bringing to this, or what my dreams and hopes are. God willing, for this idea, this project of Benedict Medicine. The idea is that rather than turnstile medicine, which is largely what we have today, if you book an appointment today, Grettelyn, with your primary care doctor or PA or whomever it is, you'll be charged a $25 copay when you show up at the door. They'll verify your insurance code so they know they can bill for the approved allotted amount from your insurance payer. And then you'll go ahead and get to see the clinician. Mm-hmm. If you have to come back in 2 weeks, you turn the turnstile again, and you do this as many times as is deemed necessary. The idea that I'm talking about, really think of it more on this scale of that there's a baseline fee. Think of it as like a cell phone plan or something like that, that really gives you access to, it really allows your physician to have the means to take care of you in all respects when it is needed and in whatever modality is appropriate. So not everything depends on an office visit. That's the other thing. In the model that we have today, the predominant model, it requires the turning of the turnstile, and that requires an office visit in order to create a billable service, right? So a telephone call with you to discuss a problem and dispense a prescription, if that's clinically appropriate, if I as a physician believe that's clinically appropriate, that doesn't turn the turnstile. The model that I'm speaking about here, this idea that undergirds Benedict medicine, is really the idea that that's not what's important. What's important is taking care of the individual in the way that is most appropriate to the individual and meets their needs and in their setting that they're in. It also involves making direct contracting with other ancillary services, things like labs, things like wholesale generic medications, and be able to dispense those from the office, be able to offer laboratory services through the practice. And the amount of markup on those things when one is billed through insurance is just unbelievable. It's really actually extremely aggravating and actually it's infuriating to consider just how many multiples of the actual cost of those services are billed through insurance. So you see your your explanation of benefits, and it says, wow, that blood test that the doctor ordered, it's a $90 blood test, but my insurance knocked off 70%. But if you actually look at it, the cost of that test when it's billed directly through your physician's practice may be on the order of a few dollars. It's really remarkable. So looking at ways to leverage all of those things to better take care of patients under one roof as a primary care physician and make it something that's accessible to people and, like you said, that is not opaque, that is very transparent, and that's really what this is about. And then respecting, of course, that patients are drawn to this model because they know where their physician stands. That's the other one. I believe that if mainstream secular medicine is afraid of the moral arguments, we need to engage more with them because there is something transcendent about this, and we need to recognize and honor that and be upfront about it and let everyone know the person who's treating them.
I think more and more people would appreciate that. Even if honestly, like if physicians in the mainstream medical establishment would be transparent with me about what they believed, I would feel better because I want to know, when you're operating on me, are you for euthanasia or against it? Like, are you going to give up on me I want to know these things about someone who basically holds my life in his hands sometimes. So yeah, I think it's crucially important. And it's kind of like a very cognitive dissonance thing that we've taken these things apart and put them in little boxes that keep them separate. So yeah, this is great work. It's fun to be interviewing you here on the ground of it.
Thank you. Yes, and I think that's the kind of piggybacking on what you just said as well, Grettelyn. The idea that that physicians and practices are devoid of a value is in of itself a value, and so when it's important for patients and for families to know, what are those values, because the idea of inclusivity, again in air quotes, is a value, and sometimes the value that's espoused there is not what we as Christians would understand as inclusivity. And so I think that's really important to say. What values are being transmitted to my adolescent when she goes to the doctor, and as a parent, you darn tootin', I should know that, and I should be able to speak to that. And so I think that it's important for people to understand that that there are two moral agents in every doctor-patient relationship, and they're both important, and there needs to be some dialogue around these important things. And that's not to speak, strictly in favor of medical paternalism by any means. I think that it's a respectful dialogue, and it's a relationship based on trust.
Yeah,
and that's what it needs to be to return.
Amen. Yeah. Wonderful. Well, this is really, really great. And we're coming up to time though. Like any last thoughts that you want to share with our listeners? Anything else on your mind?
Yeah. So I guess I would say that there are physicians out there. I think I want this to also be, I think this needs to be a joyful discussion, because the beauty of it is that we have so much to gain. I think it's easy to get dour talking and thinking about this, because it can seem like a foregone conclusion that but that medicine is, the profession of medicine is doomed. But I really do believe very much in this concept. I think that what we need as physicians and as Christians, we need to come together and really remember that this is something that we need to represent in medicine. Is just we need to restore those values. And like I said, I am building this the website. Is it okay if I give a plug to my website?
Yeah, sure. We'll put it in the show notes too.
It's in production right now, but it is benedictmedicine.org is where it will be located. And essentially, like I said, it is a nascent project. So it is really just we're trying to get people together and move this ball forward, so that we can create something together that can lift all of our local communities up with the distributive principles.
That's wonderful. And I think you're totally right. As Christians, we need to start taking things back. You know what I mean? And that's not to say, we're going to march on anything or take anything over, but we have to stop throwing our hands up and saying, oh, too bad. That's not good enough, and we know now, as we can see with the Chesterton Schools Network, that it works, that you can take back education. So this is great. Let's take back medicine too. I love it.
That's right.
So.
I think it draws, I think, so I mentioned, St. Benedict of Nursia before, but I also, I guess, just in closing too, I think a lot about Benedict the 16th, and he had some things to say about this as well, that kind of draw on that, the idea that, that the church is being distilled. These were prophetic words that he spoke in like the late 60s, but that the church is being distilled, and it's really calls upon us to grow the church from that and grow our communities around those principles. So.
Beautiful. Well, thank you so much for joining me. It's been a pleasure.
Thank you so much, Grettelyn. It's a pleasure to be with you as well.
Thank you. And again, I know you said it's in production, but we'll put that website in the show notes. Make sure that you go there and check it out. And also for us, make sure that you hit this subscribe button, like us, leave us a comment, tell us what you want to hear. If you have any thoughts for Dr. Breen, let us know. And we would love to hear you again. And again, thank you so much for coming on the show. And thank you everyone out there for listening, for joining us, because as we know, Chesterton is always better with friends. Thank you, and God bless.